All right, folks, we're going to kick off the second half of our morning, and I'm going to bring back to the podium Dr. Yasmin Krikorian, who's going to introduce our next dermatology presenter.
Okay, thank you, everybody. Sorry, coming back from the break is always difficult. Those nice bells are too beautiful, and we can't hear them and come back. So I'm Yasmin. I'm the chief of dermatology. I just wanted to take a moment because, as you probably know from your own fields, recruitment is one of our biggest challenges in all of medicine, and especially in pediatric derm. There are less than 350 pediatric dermatologists in the United States. To recruit is, to me, one of my biggest successes and important roles as a chief. So it is my absolute delight and pleasure to welcome actually someone who's been a mentor to me, Dr. Leslie Castelo-Soccio. She has joined our faculty as of 2 days ago. Woo! She's an MD PhD who's joining us most recently from the NIH, but spent many years at the Children's Hospital of Philadelphia. She's an expert in hair disorders and rare genetic dermatologic conditions, and she's going to be talking about hair disorders today. So please welcome her to the stage, but also to our community where she'll be seeing your patients.
Well, thank you, Yasmin. It's really a pleasure to be here. And really a pleasure to join the faculty at Children's National. And today I'm going to talk a little bit about alopecia and how we can, partner together to treat our patients who have hair loss conditions, specifically alopecia areata. So how many people in the room love taking care of patients when their chief complaint is hair loss? So that's me. So you can send all your patients to me. But how many people in the room spent a few minutes looking at themselves this morning, fixing their hair? Probably most of us. And for the men who are like, not me, how many men shave their beards, clip their mustaches, or have mustaches or beards that are really part of their identity? I think that would be kind of the rest of the room. A patient really put hair into perspective for me when he came in with alopecia universalis. So he had no hair on his body. And he said to me, when I was little, I had red curly hair. And so wherever he went, people noted his red curly hair. And when he lost his hair, he said that person was gone. And so, that puts into perspective how important hair is to patients. And it really has really driven me in my career to, get the best care for these patients. So I'm going to talk a little bit about how we diagnose alopecia areata and how we might distinguish it from some more common hair loss conditions that you may be seeing in your clinics. What are the common therapies that we use and the ones that you can start in your clinics before they get to see me, because we know our wait times are long. And then what are the resources out there for your patients that you can kind of refer them to, guide them to, and I think TikTok and social media are really important in alopecia and have great techniques for patients who have had hair loss. All right, so we'll start with just jump in, get warmed up with a case. So this is a 6-year-old who comes in with round patches of hair loss that are pretty smooth. This happened kind of overnight. So the mom says, I swear, 2 days ago, he had a haircut and didn't have this. And then, he wakes up and he has these distinct patches. He had no symptoms. And so she's coming in and saying, what can I do? He was referred from his school because they thought he had ringworm or tinea capitis. And so what are the things about alopecia areata that we can, know about to help us distinguish from something more common like tinea capitis? So I think this is a very experienced audience, and so you know a lot about alopecia areata, but this is an autoimmune condition. It's actually the most common autoimmune condition that exists. Typically, it occurs with small round patches of non-scarring hair loss, as you can see in the picture of this little boy. And when we biopsy the scalp, which is rare, but sometimes we need to do that, we can see that there are swarms of lymphocytes around the hair follicle. And these swarms of lymphocytes are what cause the hair to go from that growing anagen phase to catagen, or the transition phase. And when that happens, you can see on the scalp these little hairs called exclamation point hairs. So these hairs, if you feel the scalp, often feel like almost like stubble from a razor. And if you were to pull one of these hairs, they come immediately out. So this can be a really good sign that it's alopecia areata, and it's an active alopecia areata. Not every child has it, but it kind of gives you the pathophysiology of disease. And it reminds you, when you look at the histology, why we want to treat so aggressively with steroids and other anti-inflammatories, because you have this really big immune response. Not all alopecia areata is round. So this is a young girl, preteen, who has alopecia in the back of the scalp. And again, I put this because this is the translation I've been told. And so correct me if I'm wrong. I say this whenever I present this. But Chinese translation is haircut from a ghost, because again, it happens suddenly. It happens often without symptoms. And it doesn't have to be a round patch, right? So we don't have to think that this is hair pulling because it happened overnight. And so I just want to show you just another example of the spectrum of alopecia areata. When I talk about severity to other clinicians and to my patients, I always use a score. I think this is helpful for patients to have kind of where they are now and kind of where we want them to be. And so this is the severity of alopecia tool, which is a score that was initially created for clinical trials, but I use routinely in my clinic so that patients know, hey, my hair scalp score is 25. That means that they have 25% of their hair lost. And if they have 100%, that means they have no hair. And our goal is always to get to 0%. So get back to their, original baseline, which is no hair loss. And so this is an app that I created when I was at Children's Hospital of Philadelphia, which takes pictures of the scalp, and then it gives you a score automatically. But when I left Children's Hospital of Philadelphia, I couldn't use it anymore. So I just do this routinely, just, by looking. The most common things that kind of trip people up with alopecia areata is, I think, tinea capitis. And I put these examples because they can look pretty similar, right? So you have round patches of hair loss. And so these are two kids about the same age. One on the, I'm really bad with my left and right, so I'm going to say the wrong side. One has scaly red black dots when you look more closely, and this is your tinea capitis. This kid didn't have it happen overnight. His parents noticed that he's scratching for a few days, starting to get a little bit more inflamed in that area, and then he develops the alopecia, which is the breakage of the hair from the fungus that's within the hair. The child on the right has no redness, it's smooth. This happened pretty rapidly. So again, you can tell he had a recent haircut, not there, and then you notice the alopecia. So I think these are some simple things. I think symptoms with alopecia areata are pretty minimal. There are a few number of patients who really feel their alopecia areata when it first starts. They feel a little tingling in their scalp. They notice the inflammation that's kind of coming to the scalp, and they can tell me, hey, I'm going to get a new flare. But I think that's pretty rare, especially in younger kids. This is another example of, a pretty significant carry-on in a child, and then someone who has diffuse alopecia areata. Again, with the carry-on, you're seeing kind of redness, you're seeing thick scale, you're seeing kind of the oozing of the scalp. And in the child who has diffuse AA, you again see the scalp looks pretty quiet, despite the fact that deeper in the hair follicle, there's a lot of inflammation that's going on. And if you use dermoscopy or a magnifying glass, or just get really close to the area if you have good eyesight, I think now I need glasses, but you can see in a child who has tinea capitis, you see these comma-shaped or corkscrew hairs. I don't need to do a KOH or a dermatophyte if I see that. 100% of the time, if I see comma-shaped hairs, corkscrew hairs, that is tinea capitis. I never see that with alopecia areata, where if you look really closely, you see the exclamation point hairs or the fine kind of vellus-like hairs that are part of the regrowth of alopecia areata. Interestingly, in the last few years, we've done better epidemiology of alopecia areata across the US and in the UK. And what's been identified is that children who self-identify as Hispanic, Black, and Asian in the US have higher incidences and prevalence of alopecia areata. And so I bring this up because a lot of kids who are of African descent are dismissed as having alopecia areata because it's always tinea capitis, right? And actually, these kids have a higher incidence and prevalence than Caucasian children in the US. And this is true in the UK also, where children who identify as Asian, mixed race, or Black had higher incidences than their Caucasian counterparts. This has been mirrored in adults as well, both in the US and the UK. So just an important point, not to miss it in kids because you're not expecting it in a particular population. Ophiacis pattern alopecia, which is a pattern of alopecia where it kind of follows around kind of the crown or the sides of the scalp, can often be mistaken for traction alopecia. And so this is a child or a teenager who has alopecia areata. The other thing that you can see in this picture is that as the hair regrows, it often comes back white. And so it looks like this person has gray hair, but that's actually a sign of regrowing alopecia areata in many individuals. So to help distinguish kind of traction from alopecia areata, we use kind of what's called a fringe sign. So this is the fringe sign on the left-hand side. Where you can see that there's thinning around the tighter areas of the braids, which you're not going to see in someone who has ophiacis pattern alopecia areata, where you see smoothness, no redness. Again, this is kind of alopecia areata, something sudden. Traction is something that's happening slowly over time. Another key part about traction is you often see folliculitis. So if you pull the hair to tension, that causes inflammation of the hair follicle, and many people will get folliculitis. And so I use that as a tool when I'm teaching parents and caregivers about traction. Hey, if you're seeing folliculitis, these little bumps, these pus bumps, that tells me that the hair is being pulled too tightly. And so if you reduce that tension, you won't get that folliculitis, and you're also not going to get traction. So it's just a helpful technique for kind of helping parents and caregivers with hairstyling. The other kind of most confused diagnosis with alopecia areata is telogen effluvium. So telogen effluvium is when you have just diffuse shedding of hair after an event. So pregnancy is kind of the most common that people think about, but bad illnesses in children, surgeries, stressful kind of life events can lead to kind of shedding of hair. So this is a child with diffuse AA, and I'm going to show you a child who has telogen effluvium to compare. Here in this picture, though, you see the diffuse AA isn't really uniform. There's still kind of predominance in the center of the scalp. You still have areas that are really devoid of hair follicles. This is a same age child who has telogen effluvium. She had developed a really severe viral illness with vomiting and diarrhea, and then a few months later developed this shedding of hair or telogen effluvium. The number one sign that helps me distinguish these two things is what I call the bag of hair sign. So alopecia areata, for whatever reason, patients don't find the hairs. They don't bring the hairs into the clinic. I don't know why. I don't really know why this is. But every patient who has telogen effluvium, and if anyone in this audience had telogen effluvium, you know you collect those hairs. You put them on the wall in the shower. Some people put them in baggies. So I've received them in bags and envelopes, or just like right out of the purse. You know, this is the hair that I lost. And so this can be a really good sign. Like I see that, I know 100% this is telogen effluvium, and I can counsel them on that, and it's not diffuse AA. And diffuse AA is a pretty tricky kind of diagnosis, so this is a great sign if you're kind of trying to distinguish those. So what's happened with alopecia areata in the last 10 years is really revolutionary, right? So 20 years ago, when many people started practice, there was no treatment for alopecia areata. We tried to give tons of steroids, and sometimes that would work, but I'll show you that it causes relapse. But Angela Cristiano at Columbia did this very large genome-wide association study. Now it's like, gosh, is it 2000 and, in the 2010s. And what she identified is a few things. There was really great connection with other autoimmune diseases, including rheumatoid arthritis and lupus. And so many of the gene changes or polymorphisms that were seen in those diseases were also seen in alopecia areata. The second thing that this helped identify was the importance of the JAK-STAT signaling pathway. And putting this together with what the rheumatologists were already doing with rheumatoid arthritis, the idea that, hey, JAK inhibitors might be effective for alopecia came to being. And this led to many trials, first the first generation JAK inhibitors, which are broad, and then, second generations, which were more targeted. And so this was the first clinical trial where you can see each of these individuals has received, the JAK inhibitor at baseline. And as you go toward the right, right and left, as you go toward week 40, you can see the rapid regrowth of hair for many patients. The red arrow shows when they stop the medication, because as part of the trial, they have to stop the medication and see what happens. And you can see that patients rapidly regressed and went back to, no hair on their head. The bottom example, the last two rows, shows one individual where he received the medication, but it took him a lot longer to get to the endpoint of full regrowth, but did get there. And so this is an important message for our patients with alopecia. Timing can vary, but again, stop the medication and he goes back to lose the hair. This has led to probably the most rapid approval of medicines in dermatology for any condition. So we have now 3 systemic JAK inhibitors that are approved for alopecia. So there are 2 that are approved for 18 and over, baricitinib and ruxolitinib, and 1 that was approved in June 2023 for 12 years and over, ritlecitinib, sometimes known as Litfulo. Trials have been completed for baricitinib for 12 years and over. A trial is about to begin for ritlecitinib for 6 to 11 years, which we will be running. So if anyone has kids that don't qualify, call me and I'll give you my number at the end. And then trials are about to begin for ruxolitinib for 12 to 17, and we're hoping that we will also be part of those clinical trials. But most of you are not going to be giving your kids JAK inhibitors in the office. And so the end of the talk is really like, what can you do when you have a patient, and what can you start for these patients? Because you might not see me for 3 to 6 months, hopefully sooner than that. So if you don't have access to JAK inhibitors, or maybe your patient doesn't need a JAK inhibitor, there are kind of 4 options: steroids, minoxidil, both topical and oral, antihistamines, and dupilumab. And so I'll go through each of these. So steroids are still effective. I think there's this misconception that steroids are not effective for alopecia areata, and they can be, particularly in kids, and probably they absorb some of it because their heads are bigger. But the alopecia areata consensus expert study showed that steroids were effective in both 6 to 11-year-olds and 12 to 17-year-olds. And in 6 to 11, they recommend topical steroids. And in kids that are 12 and over, topical, oral, or intralesional steroids. So the evidence for topical steroids, while this short kind of message is that the studies don't have a huge number of patients, but there's a ton of clinical experience and real world data that shows that these are effective. So most patients who have mild alopecia areata, if they start topical steroids, will reach a SALT score of 20 or less in 6 months. And so you could argue, yes, some of the patients are going to regrow their hair on their own. Maybe. I mean, I think that's true, but I think you can have something that patients will want to start early, and you see that maybe a result a little bit faster. There are a number of other studies which show the benefit of clobetasol and mometasone. And again, I put those names in because you need strong steroids. You cannot put hydrocortisone 1% on alopecia areata and expect the hair to regrow. You need a class 1 steroid, the strongest steroid, for it to be effective, especially if you're only using topical. This is an example of a paper where, a topical regimen was used. This is typically what I use. I'll use an ointment or solution depending on hair texture. Twice a day, weekdays for 4 weeks. I know that gets into people's heads like beyond 2 weeks, but you need to use it for 4 weeks. Then I go to once a day for 2 weeks on weekdays. So I'm giving that break on the weekend or for non-compliance. And then you go off for 2 weeks and then you can repeat that cycle again. This is effective, and this is probably what you should do if you have a patient who has alopecia areata and you're referring them to us. Intralesional steroids are a little tricky. Meta-analysis shows that it's effective, but you can get atrophy. And so I have seen many kids who have gotten high doses of intralesional steroids and have divots all over their scalp from that. It's most effective if you use 5 milligrams per milliliter or less, which is what I use. I don't do it in kids under 12. It is traumatic. Every adult I've ever met with alopecia areata who got intralesional steroids as a kid remembers that as a highlight of their childhood. So please don't recommend that. And if their dermatologist wants to do that, please advocate for them and say, let's not do that. There's a rare 7-year-old who can do it. And I've had those kids who are like, whatever, inject me. And I have done those kids, but most kids, even teenagers, have trouble with doing this. You can use ice and Buzzy, which can help with the pain. It is painful. Systemic steroids, good effect on growth, but high relapse after cessation. So if you're going to use steroids, you know that you're going to get kind of loss after a period of time. So it's a bridge to other therapies. This is my pulse dose regimen. So if you want to look at this later, I use either dexamethasone or prednisolone, and depending on weight, I tailor it. Antihistamines are used widely in Japan for alopecia areata, and there have been 11 studies that all of them coming out of Japan about their usefulness. There's a thought that fexofenadine in particular has some effects on interferon gamma, which is really important in the JAK-STAT pathway and may have more benefit than some of the other antihistamines. There's also some other hand waving about what it might do to cell migration. So if you have a kid who has atopy or allergies and alopecia areata, why not give them fexofenadine, right? You might be giving that to them anyway. There's a great link with atopy and alopecia areata. A high percentage of children with alopecia areata have atopic dermatitis, and this is more than the general population. We also did a study looking at seasonal flares of alopecia areata, and in those kids who had atopy or seasonal allergies, it kind of correlated with their flare season. So again, this can't hurt to start. And this is why probably dupilumab is effective for a subset of patients with alopecia areata. So there was a study in adults which showed that adults with atopy or elevated IgE levels had better responses to dupilumab, and many fully regrew their hair. And there have been real-world studies in the pediatric population showing something similar. So for me, I look for patients who have an IgE level greater than 200. I look for patients who have significant atopic dermatitis if they do, because great, I can get dupilumab on label, whereas alopecia, it's off label. So this is great. Or if they have asthma, this is great. And I saw our asthma expert. And then last, I'll end with minoxidil. So minoxidil, and if anyone reads the New York Times, it's had this resurgence as the best medicine for any hair condition. And It does help prolong anagen, and one of the major problems in alopecia areata is the forcing of the hair from the growth phase anagen to that kind of transition phase catagen. So if you can keep that hair in anagen, you can prevent the alopecia. It also helps with beta-catenin and Wnt signaling, which is really important for the stem cells of hair follicles. So there's evidence in adults and kids, and we see that topical and oral works. Topical, we do see some irritation and contact allergies, so be aware of that. Hypertrichosis is a real thing. I don't know if my patient population just genetically is a hairier population in their families. They get on minoxidil and they're very hairy, but most people don't mind that. There have been two important papers that have come out from international Delphi consensus statement and then from the European alopecia experts, which have looked at low-dose oral minoxidil for alopecia areata. And among kind of the experts worldwide, they all agree that it's safe for kids greater than 12. It provides benefit. And then they provide dose ranges in this article. And the European expert consensus actually considers oral minoxidil to be an adjunct to any therapy for alopecia areata. And so that's circled in red. And this is how I prescribe. So if I'm doing minoxidil, I do 5% solution once a day. The foam doesn't contain propylene glycol, so if you're worried about allergies. And then oral, you can look at kind of the dosing. Minoxidil is toxic to cats and dogs, so you do want to be cautious about it. So if you're going to put a ton on your head and then have your cat sleep on your head, not a good idea. So I like patients to be aware of that because, you know, our pets are important to us and they may not want to use it for that reason. There are a lot of resources for families. So the National Alopecia Areata Foundation has wonderful resources. The Society for Pediatric Derm I created the school nurse resource, so you can give it to your school nurses. There are a lot of books. If kids are missing eyebrows, there are temporary tattoos called My Two Eyebrows, which are like amazing and they look better than typical eyebrows. And then if you want camouflage, you can use root cover up. So what you use for gray hair, kind of put it right on, and it does help camouflage those patches. I'm having a hair disorders clinic that will occur on Fridays, twice a month. I will see hair patients throughout my general clinics too, but if you want to reach me or have a patient with hair loss, please reach out to me. So I hope we got through the objectives. Thank you.